Hello, everyone, and welcome to today's webinar, Protecting Children's Health, Ensuring Vaccine Access Through Strong State Policies, hosted by the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health. Just a few notes before we begin. We'll have time for questions after the presentations have concluded, so you can hold any questions until the end and then enter them in the question box. And a recording of today's webinar will be made available in the coming days. Now I will pass it over to Dr. William Moss, a professor here at the Bloomberg School of Public Health and the executive director of the International Vaccine Access Center.
Thank you very much, Tori, and welcome to all of you. On behalf of the International Vaccine Access Center at the Johns Hopkins Bloomberg School of Public Health, we want to welcome you to today's webinar. We're grateful to have a diverse audience joining us today for a discussion of the ways to strengthen immunization policies and protect the health of American children. Today's session will bring together policy analysts and experts working on the front lines of state-level policymaking. We'll discuss policy trends, strategies to combat anti-science bills, and resources that you can use to support evidence-based decisions and advocacy efforts in your own jurisdictions. Today, we're joined by Rose Weeks, who is a senior research associate here at the International Vaccine Access Center, and who studies how policies and practices can optimize vaccine access. We're also joined by Jack McClure, who monitors state vaccine-related legislation as the State and Policy and Research Associate Director for the Association of Immunization Managers. In addition to Rose and Jack, we have three special guests joining us from Louisiana, Oregon, and South Dakota, who will speak about their work to advocate for strengthening state immunization programs. So we're first going to hear from Rose, who will discuss national trends in vaccine coverage, non-medical exemptions, and immunization data access. Rose, over to you.
Thanks so much, Bill. As many of you are aware, 2025 has seen the largest number of measles cases in 1 year in more than 3 decades. Measles has been making headlines across the United States, and with this greater interest, the International Vaccine Access Center launched a tracker to represent laboratory-confirmed measles cases reported by public health authorities from state and county health departments. This is of great interest because measles is a tracer for many reasons, but including measles is a tracer. It really represents the canary in the coal mine for the overall strengths of a public health and immunization system. Outbreaks are effectively biomarkers for the status of immunization implementation. So taking a step back, we wanted to understand, why were we seeing cases emerge across the United States? And why were cases sometimes isolated, like these red dots on the map that represent imported cases, and in other places blooming into outbreaks, like the bigger blue dots, for example, in South Carolina most recently. In this presentation, I will highlight some policy choices states are taking that enable these outbreaks to take hold, and that discussion and those insights will continue with the next presenter, Jack McClure. To explore policy choices made by lawmakers at the state level and better understand why we are seeing outbreaks take hold in some places but not others, we launched a series of policy briefs in September 2025. These are 4-page documents that are summarizing what the states have selected to do in terms of non-seasonal vaccines recommended for all U.S. children. Our audience is immunization coalitions, members of the media, with an ultimate goal to reach decision makers with actionable data. The indicators are about 7, including coverage, use and mechanism of exemption, public health spending, new and proposed laws, and more. Some of which we'll highlight in this presentation, but all of which are available in the briefs themselves, which are available through the QR code linked from this image. We also want to mention that we've had gracious support from state epidemiologists in all of the 50 states and the District of Columbia, who've graciously reviewed the content for us as well as some of our partners. The briefs start by reporting on coverage for measles and DTaP at the state level. National coverage for the full coverage of MMR series is estimated at 93%, which is fairly high at a national level, but this ranges considerably, as you can see on the map. It ranges from a low of 80% in Idaho and a high of 98% rather, in West Virginia. 12 states have exceeded Healthy People 2030 targeted coverage of 95%, which is excellent. And 4 of them, non-coincidentally, only allow for medical exemptions to school mandates. The briefs also include current uptake of non-medical exemptions, so more about that. These are mechanisms to allow individuals for school or child care entry to opt out of required vaccinations due to personal or religious beliefs rather than a specific health condition. Medical exemptions are a valid reason to opt out of vaccination in all 50 states. All but 4 states currently allow non-medical exemptions. This ranges considerably, though. Nationally, the rate is 3.4%, and it ranges from a low of about 1% in Mississippi to a high of 15% in Idaho, with exemptions increasing in several dozen states. 36 states saw the proportion of children getting exemptions increase in the past few years. So almost all of the states that allow, well, many of the states that allow for personal and non-medical exemptions. And then 17 states report exemption rates over 5%. So that is fairly high, especially when you look at where we were a few years ago. Another aspect of this is really non-enforcement of immunization requirements. And so that is a major cause for really a lot of variation in coverage from state to state and also within states. We also have taken a step back and looking at the exemption policy. How hard was it for families to get an exemption for their child in all 50 states plus DC? States can make it very easy for families to get a non-medical exemption. In many states, as you can see, a little bit more than 55% of them, you can simply sign a note or download a form from the internet to get a non-medical exemption. So at the higher end of things, maybe the less convenient end, you can as a state, require a form to be notarized. So what we did was we classified the policies for each state into highly convenient, moderately convenient, and less convenient. And as you can see, like the majority of the states by far have either highly convenient or moderately convenient exemption policies. The friction the process adds is really critically important. It helps to strengthen public health protections. In this case, we actually don't think convenience is helpful. And moreover, there are new findings that show, for example, in an earlier study in Health Affairs, that these processes are very important to the spread of disease, controlling the spread of disease. States that had processes making it more convenient to get vaccine exemptions had higher rates of whooping cough. Understanding variations in vaccine coverage at the county level rather, is critical for decision making. So up to now, we've been really looking at the state level, which has lots of different data sources and is generally pretty reliable. When you get down to county level, it can be highly variable what the quality and the comprehensiveness is from state to state. And so we looked at one part of that, and that's vaccine registries, and we really found these policies for use of these really integral information systems vary a lot among the states. And so at left, you can see the policies related to child consent by the jurisdiction. So these are by the state. I think that there's a few extra registries within some of the states, but generally you can see that the vast majority of states have either implicit consent or mandatory inclusion, which is sort of the opposite of sort of taking a step back and making this explicit consent, which is you have to sign a waiver. There's a sort of a consent process, but before your information goes in, before your child's information goes into the registry, which is in some cases less efficient and cumbersome, and certainly probably does affect the comprehensiveness of the data. So that's a policy choice. And then at right, we see the school immunization reporting and how they get their school coverage estimates into, what is the relationship with the immunization registries. Some of them are highly integrated, the school reporting, which potentially really does increase convenience for families and school officials reporting coverage to their health departments. And so that's an area of great interest to us, and we'll be looking to release a summary of all the policies across states when it comes to immunization registry in the coming weeks. Also included in each of the briefs is a brand new estimate of how much measles outbreaks generally cost. And so we found that the average cost of measles, my colleagues in the economics team at the International Vaccine Access Center, you can read the systematic review if you click on the QR code on this slide, found that the average cost of measles cases is about $43,000, but this varies by state and outbreak characteristics. One thing that was very important in this systematic review that potentially was overlooked before is the substantial stand-up cost of just beginning your outbreak response, which is a fixed cost of roughly $244,000 due to investigation, contact tracing, quarantine, vaccination, and rapid response efforts. After that stand-up cost, you have an incremental cost of over $16,000 for each measles cases. So we really are hoping these findings reinforce the need for policymakers to better budget for measles response and highlight the financial burden of declining MMR coverage. Just a reminder, you can download the brief summarizing the child vaccine policy and practice choices for each state and the coverage detail at this QR code link. And just a note that these briefs are updated on a monthly basis to reflect changing measles cases across the US. We are also really excited to launch web pages that have the same information, but maybe a little bit even more lay-friendly than the PDFs. So that'll launch later this week. And we invite you to be among the first when we launch these and other advocacy resources to the public. If you scan the QR code, you can subscribe to our emails. And I'm sorry, I have one more QR code for you, and then I will turn it over to Jack. We have an upcoming event that we welcome your participation in. This will be at the Johns Hopkins Pennsylvania Avenue building. It's called the Bloomberg Center, and this will be an exciting opportunity to work together with partners to sustain the gains of childhood vaccination in an uncertain climate. This will be an in-person meeting, and we encourage you to sign up for interest. It probably will be either February or March, so more to come on this. Next, we will turn it over to Jack McClure of the Association of Immunization Managers, or AIM, for more information on the state policy landscape from the past year. We heavily used the AIM legislative roundups to synthesize policies focusing on childhood vaccines at the state level for our policy brief series. So really are so grateful that Jack could join us today. Over to you, Jack.
Awesome. Thanks, Rose. And good afternoon, everybody. As mentioned, my name is Jack McClure, and I'm happy to be here today on behalf of AIM to share some of the national trend data related to state legislative sessions. Next slide. So the Association of Immunization Managers is a nonpartisan, nonprofit organization that represents all 66 federally funded immunization programs across the country, including the programs for all 50 U.S. states, 8 major U.S. cities, and 8 current or former U.S. territories. As a part of our work and a vision of a nation free of vaccine-preventable disease, we support immunization programs as they navigate through their state's legislative session each year, a task that has become increasingly more involved in recent years. Next slide. So state legislative interest in vaccines has grown notably over the past several years, and the upward trend really started before the COVID-19 pandemic. In much of the early 2000s, vaccine-related bill volume was quite low, maybe a couple dozen bills related to vaccines across the country being introduced without much fanfare and with very few gaining much traction. But that number really began to climb in the 2010s, and by 2019, we had reached more than 300 vaccine-related bills cumulatively across states. As you can see on the screen, this number really exploded during COVID, with 809, 594, and 690 bills proposed nationally that were related to vaccines between 2021 and 2023. Then in 2024, using the same timeline and search criteria that I'm going to present for 2025 in a second, AIM identified 363 effective vaccine-related bills, sort of suggesting the surge driven by the pandemic might be subsiding. However, 2025 brought a rebound interest in state vaccine policy, which I'm going to walk through here today. Next slide. So really throughout the year, AIM staff flag and track all proposed vaccine-related state-level legislation utilizing Fiscal Note software. We also work closely with our members in the states and other partners throughout legislative sessions to monitor and respond to bills with frequent touch points, meetings, and biweekly reports. AIM also publishes a cumulative state legislative report summarizing legislative activity, which for this past year was from August 1st, 2024 through June 1st, 2025, data from which I'm going to be sharing on the following slides. Now, this is not a perfect timeline, as some states have year-long legislative sessions, special sessions, or slightly later end dates, but it captures the vast majority of each state session, and it allows AIM to be able to compare counts and themes between this year and the previous one. Every vaccine-related bill is counted, summarized, and categorized by theme. And while most get captured through the search terms on the screen, we also identify bills that, do not use the traditional vaccine or immunization language through a variety of sources. Unfortunately, legislatures have gotten a lot more creative in how they introduce vaccine-related bills, trying to maybe sneak them through the cracks or have them, go towards a non-health related committee of jurisdiction. So next slide, I will start with some top line national numbers for last year. AIM tagged 668 total vaccine-related bills between August 1st, 2024 and June 1st, 2025. This is 171 more than the 497 that we tagged last year during the same period, or a 34.4% increase in overall vaccine-related bill volume. Next slide. So in some states, it's commonplace for the exact same bill language to be introduced simultaneously in both the House and the Senate, although it's functionally still one piece of legislation for an immunization program or an advocate to track throughout the process. So accounting for this, quote, duplicative legislation, and this is our number that we usually go for the year, AIM identified 547 effective vaccine-related bills. And this 547 number is 184 more bills than the 363 that we tagged last year during the same period, or a 50.7% increase in vaccine-related legislation nationally. And as you can see on this map, and apologies, it's a bit small, but the number of vaccine-related bills encountered in each state varies significantly, from dozens of bills being introduced in some states to no bills being introduced in others. Next slide. Of the 547 effective vaccine-related bills, 37 bills were enacted by the legislature between August 1st and June 1st. Again, several more trickled in later in the summer and during some recent special sessions, but overall, still accounting for those, the count of vaccine-related bills making it all the way through the state legislative process remains quite small. 5 of these bills, after they passed their legislature, were subsequently vetoed by their governor. The legislature was able to override the veto of one of them, which resulted in a total of 33 vaccine-related bills, or 6% of the total volume, becoming law as of June 1st. And again, as you can see on the map, the number of bills enacted varies significantly between states. Next slide. So this chart shows how far each of the bills that AIM tracked made it through their respective state legislative process. And I think the key takeaway here is that while the majority of bills failed to pass, we did see 111 bills pass their chamber of origin, right? So that's close to 20% of bills introduced passing an entire legislative body. So some of these once more fringe vaccine-related themes that I'm going to talk through in a minute are not so fringe anymore, right? These message bills are becoming more than just a message and are getting really close to the finish line. You can see that more than half of those bills that get through one chamber will also get through the second chamber, right? 64 bills got all the way through their state's House and Senate. So while the vast majority of bills still are not reaching enactment, we're seeing more vaccine-related legislation get closer and closer to the finish line each year. Next slide. So I'm going to spend the rest of my time on this slide, so I'll walk through it. But essentially, AIM categorized all 547 effective vaccine-related bills into 18 primary themes as pictured on the screen. And each of these themes is discussed in much more detail within our cumulative state legislative report. I'll drop that in the chat shortly, but I'm going to try to walk you through some of the key thematic trends, in my opinion, right now. So in the table, you can see each of the themes we identified listed. The number of bills in each theme category is in the second column, while the third column shows the percent change in bill frequency compared to AIM's report from last year. And so as an example, we can start at the top. We saw 34% more bills related to vaccine requirements and exemptions last year compared to the previous one. And speaking of vaccine requirements and exemptions, as Rose introduced, that remains far and away the most common vaccine-related bill in state houses. We saw 153 bills last year, largely seeking to either remove established vaccine requirements or simplify the process of obtaining an exemption. And legislation here focused on vaccine requirements in a variety of settings, including K through 12 schools, requirements at colleges and universities, employee vaccine requirements, daycares and preschools, even at healthcare facilities. If you were, visiting a patient, the healthcare facility couldn't require you to be vaccinated to make that visit, for example. And this is a trend on requirements and exemptions that I expect to see continue. We saw Children's Health Defense recently say that the state-by-state removal of school vaccine requirements is one of their top priorities as an organization. There's currently numerous active lawsuits in states across the country seeking to curtail vaccine requirements or expand exemptions. So definitely keep an eye on this one. Next up, we saw 58 bills involving prohibiting discrimination and/or service refusal due to one's vaccine status. And bills here were involving reported discrimination in healthcare facilities, employment, or in public spaces, at times even seeking to add vaccination status as a protected class similar to race or ethnicity. I would say that this health freedom movement trend definitely peaked during COVID, but it's still quite invigorated, very active, and poised to continue to grow as well. The next two themes on the chart, vaccine cost and ability to vaccinate, were largely in support of vaccination. So we saw 51 bills related to vaccine cost, coverage, and/or reimbursement. And these were largely trying to somehow limit cost barriers to vaccine for both providers and their patients. And then we saw 47 bills related to the abilities of various professions to be able to vaccinate. And so bills in this category were those trying to expand or somehow specify the vaccinating authority of professions like pharmacists, pharmacy technicians, nurses, first responders, really allowing these professions to administer additional vaccines to additional ages. And we really saw this trend peak during COVID vaccine rollout, right? As states sort of realized how important providers like pharmacists were for vaccine access. However, this remains a focus of many state legislatures and groups for continued routine and respiratory vaccine access as well. Can expect more movement here in the year ahead as well. Vaccine communications is next up on the list. That was the next most common theme, 34 bills here. And unfortunately, these were largely seeking to curtail how vaccines were promoted, discussed, or otherwise communicated about with patients. We saw bills here seek to limit how immunization programs promote vaccines, such as requiring that any communication that encouraged vaccination would also include information about obtaining an exemption or about the risks of receiving that vaccine. And I think as this push for this sort of informed consent continues, which in practice we're seeing really just means getting more information about vaccine risks to patients, this is also a trend that I suspect to continue to grow. And so I'd say that rounds out our top 5 themes from last year on the chart, but I'm going to quickly call out a few others that I think are important to keep an eye on in the year ahead as folks think about strong immunization policy. So one is on mRNA vaccines. We saw 32 associated bills last year. And since COVID, we've really seen this continued push to outright ban mRNA technology, to label or test, blood products for mRNA components, and really just a slew of other deeply misinformed concerns about mRNA vaccines. And even though we keep moving further and further away from the peak of the pandemic and COVID-19 vaccine rollout, you can see that last year we saw a 220% increase in mRNA bills. And so this topic is still top of mind for many state legislatures, and especially as it continues to be discussed at the federal level, advisory committees as well. I'd also call folks' attention to the liability and lawsuits theme around vaccine injury. That's another one to look out for. So we saw several bills last year either looking to make vaccine manufacturers liable for vaccine injury, as well as bills that were even trying to make the school or the employer or the state that requires a vaccine liable for any injury, that's associated with someone receiving a vaccine in accordance with those requirements. Next, I would mention sort of under the umbrella of the vaccine safety theme, which only saw 29 bills last year. I would definitely anticipate more bills related to vaccine ingredients and components making their way across state houses. There's been increasing conversations about ingredients like thimerosal and aluminum adjuvants, for example, at ACIP. And so I think as these discussions continue at the federal level, we're likely to see them trickle down to state houses as well. And on that note, the final theme I'll call out from last year is federal government response, way there at the bottom. While we only saw 3 bills as of June 1st, we've already seen this trend continue to grow in recent special and year-round sessions, some of the pre-filing that started, and I suspect that it's really going to explode in the next year. And really, I think of these bills as either directly following or more often than not directly contradicting some of the recent federal policy changes that we've been seeing under the new administration. And so I think as the federal government is poised to make even more direct changes to ACIP, to immunization infrastructure more broadly, we're going to see more state legislatures, try to be that person for their state and implement some of these discussions at the federal level, at the state level, or reversely, we'll see some states try to distance themselves further and further from the federal government, within their statutes or references to ACIP, for example. I'd end with expect the unexpected as far as themes go. We're bound to see some new themes emerge as well. We always do. We have to respond in real time. However, I'll flag that we continue to see time and time again boilerplate vaccine-related legislation get introduced in multiple states. And so if you're in a state and you're encountering a bill that's unexpected, I would say it's still more likely than not that another state is also encountering that bill, or maybe they encountered it last season. So information sharing and collaboration is critical. And next slide, I think that's my last one. So I will end my presentation. Happy to answer any questions at the end. And again, would definitely encourage folks to read through our full report to learn all about the themes percolating across the country. So thank you so much.
Jack, thank you very much for this detailed explanation of the work of AIM in this very important space and for your insights into what we may be seeing going forward in terms of legislation to minimize access to vaccines. So thank you very much. So we're going to turn now to a conversation with our state vaccine advocates who are joining us from Oregon, South Dakota, and Louisiana. We're going to start with Crystal Rahman from Louisiana. Crystal is a licensed clinical social worker who leads Louisiana's Families for Vaccines, and she will be sharing a brief presentation on recent trends and how Louisiana state officials are communicating about vaccines and what type of materials help her and her organization to emphasize the importance of protecting childhood immunization programs in conversations with Louisiana lawmakers. So, Crystal, we're excited to hear your presentation.
Thank you, William, and thank you everybody for coming today and giving me the opportunity to share about the vaccine landscape in Louisiana. No conflicts of interest or anything like that. I just wanted to start out with 2022. Louisiana Families for Vaccines has been in existence since 2022, but most recently in 2024, we had a new Surgeon General appointed who publicly declared that the Louisiana Department of Health was officially ending all vaccine promotions. That means no vaccine education or community outreach, including mass vaccination clinic events. And he said in a statement that in general, the department is shifting away from a one-size-fits-all paternalistic guidance to a more informative approach aimed at enabling individuals in consultation with their doctors to make these decisions. And so rather than having a public health framework, they're moving it more to an individual health framework. This torch was also carried by our new Surgeon General, because a couple weeks ago, our Surgeon General was appointed to the second in command at the CDC. And so his replacement has said that, she wants to continue this shared clinical decision-making model that we're seeing. She also is on the ACIP committee that just last week voted to remove the universal hepatitis B infant dose. So that's kind of a snapshot of where we're coming from. And as far as the messaging around this, we saw this starkly in this pertussis outbreak. I first want to just highlight the great work that the New Orleans Health Department has done around messaging. They said, if you or your family members are not up to date, get vaccinated as soon as possible. Clear, direct vaccine recommendations. However, we found out just in October of this year that the Louisiana Health Department waited several months after they received news of the pertussis outbreak before they informed the public. And then as we're looking at their messaging, they said you should talk to your healthcare provider about their vaccine history and whether they should receive a pertussis vaccine. And then just a few days ago, our new Surgeon General was talking about the flu and said, if you're interested in the flu vaccine, ask your doctor about the risks and benefits to choose what's right for you. So again, emphasizing this individual decision making. And so just to highlight, I want to give you the slides you can look through more in detail on your own time, but the 2025 legislation really did emphasize access. House resolution, which isn't as strong as a bill or a law, but at least a recommendation that the Department of Health provide access to vaccines in areas of need or underserved areas. And then this House Bill 690 started out as a bill, but then they decided, no, we don't want it to become a law. We would rather just allow our Surgeon General to promulgate rules around emergency use authorization, medical activities. And so we're seeing this shift away from, legislative authority into unilateral authority for our agencies to promulgate rules. In 2024 legislation, a lot was focused on vaccine school requirements, specifically emphasizing COVID vaccination, that no public or private school can require students to get a COVID-19 vaccination. And then this emphasis on communications around exemptions, and just kind of like what Jack said, a lot of legislation was introduced around vaccine exemptions. So these are some video clips that I linked that you can also see. I think Rose is going to share the links afterwards, but this is a video of our Surgeon General saying that, our Deputy Surgeon General rather, that there is a possible connection between vaccines and autism. In our next slide here, we have our Surgeon General saying the worst thing Louisiana did in our pandemic response was to recommend the COVID-19 vaccines to children. And so Jack kind of went over this at length, and so I won't touch on it now, but we see a lot of these anti-vaccine topics emerging in Louisiana as well. A lot of bills went through 2022, which only one had to be vetoed by our governor. But now that we have an administration that is a little bit more aligned with the anti-vaccine agenda, we're seeing more of these bills getting through. So probably the most important thing that we want to talk about here is, what can we say that lands with lawmakers, that strikes a chord with the decision makers? And so we have found good success with messaging around protecting access. Like, even if there's vaccine choice or there's exemption choice, we still want our parents to have access. And that includes our vulnerable populations, those children who are on Medicaid, and that the Vaccines for Children's program needs to be covered. just like that House resolution to preserve vaccine access in underserved regions. Also, House Bill 655 passed, which increased revenue for health units. We're trying to also workshop this freedom language that we have the freedom to live in a society free from vaccine preventable diseases, and that parents deserve the freedom of choice to access vaccines. Also, Louisiana is a very underserved region. We have a lot of natural disasters, and so there is this mentality that Louisianans take care of their neighbors. We've also seen success with our business and industry partners who are communicating that there are benefits to their employees' vaccinations that protect productivity and the economy. And then thankfully, people still are overwhelmingly trusting physicians as trusted messengers. And so we are trying to launch an initiative in collaboration with the American Academy of Pediatrics to have an on-call physician for policy questions during legislative session. And so here's just an example of some of the messaging that we have social media campaigns running for right now. This Christmas one, this cute baby, parents deserve the freedom to protect their children. Tell LDH to ensure access to vaccines, clear info, and the freedom to choose. And then we are the sportsman's paradise in Louisiana, so a lot of hunting and fishing, and have cute kids. Cast your net of protection wide and demand broad access to vaccines. We have had some success with some data that I wanted to just touch on very briefly. If you can go to the next slide, I'll kind of show the pictures of what we've done. We've taken the school vaccination rates based on parish and even broken down at the school level, which is publicly available on our state's immunization dashboard, and created a one-page flyer that we can give to legislators and show them what schools could possibly be at risk for a measles outbreak. So the red column are states that are at risk, and the black ones are adequately covered. And if you can see across the state, about 2/3 of our parishes, we have parishes, not counties, but the parishes are at risk for a measles outbreak. And so what are we doing about it? We are organizing grassroots efforts, boots on the ground. We have calls to action, including thank you campaigns for legislators when they are trying to promote good vaccine legislation. And so we have federal and state calls to action, but mostly state during the legislative session, opportunities for advocates to go to the Capitol as well. You'll see on the next slide. Louisiana Families for Vaccines is one of 12 and growing state chapters across the nation. And we just are so grateful for the support of American Families for Vaccines and being able to do this work. And so we invite you all to scan this QR code and get involved with your local state chapter. And share information with folks in other states who are looking for the opportunity to make their voices heard as a pro-vaccine majority. If you want to learn more about what we're doing in Louisiana specifically, we do C3 and C4 activities, community outreach, education, and advocacy, and we would be honored to partner with you in initiatives, education, outreach events, as well as advocacy. So thank you all for letting me share and getting to do this good work together.
Thank you very much, Crystal. It was so important to hear that some of the challenges you're facing in Louisiana, but also how you and Louisiana Families for Vaccines have really tried to tackle this by. I really like the language you use and the framing. Protecting access and freedom from disease, and how Louisianans protect each other as neighbors. I think that very positive framing is really important. So thank you very much, Crystal. So we're next going to move to Meg Olson from Oregon. And Meg serves as the state director for Oregon Families for Vaccines, where she educates lawmakers and works with a community organization. So Meg's going to be discussing Oregon strategies for ensuring vaccine access and how the state is responding to changes in the ACIP. Meg. So we'll see if Meg can get a better connection, but What we'll do now is transition to Carmen Toff from South Dakota. Carmen directs the South Dakota Families for Vaccines, working to advance policies that promote preventative and primary care. And Carmen will be discussing policy trends and partnership strategies in South Dakota. So, Carmen, over to you.
Wonderful. Thank you so much for having me. We're set up very similarly to Louisiana, so I'm going to skip over kind of how we're organized. But we were established in 2023, so we are moving into our fourth year, and it will be our fourth day at the legislature coming up here in February. Next slide. So like Crystal said, we're a volunteer-driven organization. We work with parents, pediatricians, childcare providers. Everyone has a role in keeping our community safe. And so we try and find this grassroots network and get them in front of policymakers and decision makers so they can speak to what is important to them in keeping our community safe. And then a little bit later, I'll talk about some of the organization partners that we have. Specifically, I want to talk about our exemption law that we saw earlier this year. Currently, our immunization law requires children entering school to be vaccinated against a list of vaccine-preventable diseases, and there are two exemptions. So we have medical and religious. Our medical exemptions have been holding strong at 0.2% of kindergartners. So that is not an exemption that has changed much over the last decade. However, our religious exemption is a written statement from a parent or guardians that they're adherent to a religious doctrine, but it could be anything. There is no system where we check, and those religious exemptions are growing in South Dakota. Unfortunately, we're up to 5.4% of kindergartners within the last school year compared to 1.5% a decade ago. So we are definitely one of those states that Rose mentioned that our exemptions are over 5%. And this year, we almost had another one added. So this was our conscience exemption that narrowly failed out of the full body. And it was a bill to grant individuals the right to refuse medical treatments that violate their conscience, and then prohibits any disciplinary action, discrimination, consequences in general. So this type of exemption is generally considered a conscientious or philosophical. And so when we're speaking to advocates and allies, we use the term philosophical more, because it is much easier to say. And vaccines are not a moral issue. So we did use conscience in this circumstance because that is how the bill was written. So you can see some of the talking points and testimony we pulled together, next slide, are similar to what Crystal was talking about. We say, allowing folks to opt out more easily leaves our state vulnerable. And even though it's sometimes easier to opt out than it is to organize time off, get transportation, childcare for your other kids, it doesn't mean that these parents are anti-vax or even questioning. It is a matter of access, but we want to make it more difficult because we know how important that these vaccines are. And similar to Louisiana, we use a freedom theme kind of throughout, freedom from the threat of vaccine preventable diseases. And then we were very successful partnering with the business community. This says that there was several provisions that violated South Dakota's at-will employment laws because it prioritized an employee's inner conviction over the business owner's right to protect themselves, their business, their customers. And then it allowed those employees to sue and then also collect 3 times the actual damages and attorney's fees. And so if you're running into a roadblock where you're like facts and science, and over here it's do it for the children, really look at an economic argument and see if you can partner with some different kind of organizations that maybe you aren't healthcare focused, but they do show this will affect the economy of your state. And then again, we already have exemptions in place. We don't need them. So we too are a pro-vaccine state, and we took 90% of parents that vaccinate their children in South Dakota, and we're building on that. And next slide. some of the organizations that we have a partners on the patio, so we invite our Cancer Society and the South Dakota Association of Healthcare Associations and our legislators and anyone who's really interested to come and have a conversation and be more casual before we get to the, oh my gosh, we're fighting this legislation and everything is really, really urgent. It's nice to be able to kind of get together in a more casual way. And that's it. That's it for me.
Carmen, thank you very much. And, thank you very much for all the great work that you do. It's interesting to hear, the theme of freedom, using the language of freedom from disease. I guess, in a state like South Dakota, where access issues are also very important and how you dealt with that. And then the economic angle. So some of our traditional messaging, as you pointed out, is not working perhaps as well as we would, but there are other angles that we can take, and economics being one. So thank you very much, Carmen. And we're going to go back to Meg Olson from Oregon, Oregon Families for Vaccines. And Meg, I'll turn it over to you.
Hi, thanks everyone. I'm so sorry about that. I'm not quite sure what happened. Can everyone hear me now?
Yes, now
Thanks.
it's good, Meg. Great.
Just wanted to check that. Okay. So jumping right back into talking about Oregon's vaccine finance system. So Oregon has a state vaccine finance model called the Vaccine Access Program that is pretty similar to a universal purchasing model in function, in that it's a bulk purchasing system, but it's not actually universal. It's an opt-in program that was established with one pot of funding about 20 years ago. Clinics that are enrolled are able to access vaccine stock at no upfront cost. And then once they've billed insurance, they've administered a vaccine, billed insurance, or the Vaccines for Children program, then they reimburse the state program. So it's operated off of the same recycled pot of funding for decades. And the reason that's important is because it shows that this model is pretty unsustainable, given the changes to our vaccine schedule. You can see on the table that the program staffing levels have barely increased, but the enrolled clinics are exploding, and the number of vaccines that the program manages now is thankfully drastically increased. But it means operating off that same pot of funding is not a sustainable program. The program already has a long wait list of providers that are interested in enrolling, but without any additional funding, the program is actually set to start to disenroll clinics or close entirely sometime in the next year. Oregon Families for Vaccines is part of a stakeholder group that is looking into other models or additional changes we can make to the current model, looking at options for a universal purchase model that has a more sustainable funding structure. But it's actually been pretty difficult to get stakeholders to come to a consensus on what a model in Oregon could look like, because the universal purchase model looks pretty different in every state. But it would be pretty important and impactful, particularly for rural areas in Oregon where independent providers face cost barriers to stocking vaccines. We saw that a little bit. We heard Jack talk about vaccine cost as a new legislative trend that's coming up in different states, and that's definitely in Oregon. If we want to go to the next slide really quickly, I'll just gloss over. Oregon has non-medical exemptions. We don't differentiate between religious or philosophical. We just call them non-medical, and we can skip to the next one, the next slide. That our non-medical exemption rate has been drastically increasing. Oregon recently did a survey of those who are requesting non-medical exemptions, and overwhelmingly they are citing access as an issue, really showing us that it's easier in Oregon to get a non-medical exemption in some areas than it is to get a vaccine. So a new purchasing model is really kind of a first step towards broadening those access points. We've talked a lot about how access is so important. The next thing, we can go to the next slide. And then the last thing I just wanted to touch on was how the changes to the advisory committee on immunization practices are how Oregon is responding. So far, Oregon actually has joined the West Coast Health Alliance, which is determined to put out its own recommendations on vaccines. Other states we saw already, we heard from Jack's presentation are passing legislation to kind of broaden any language in their statutes that refer or defer to ACIP decisions or recommendations. And Oregon is not yet committed to making any such change, even though we have several state statutes and rules tied to ACIP and CDC recommendations, including laws around what insurance has to cover, what vaccines can be given in a pharmacy setting, school vaccine requirements, and other things like that. So without taking that legislative step, our participation in the West Coast Health Alliance is nominal at best, and there's likely to be a lot of confusion surrounding vaccine access as ACIP continues to make changes to the recommended schedule. We are working really hard in Oregon to mobilize our advocates, but our state has spent a lot of time identifying what changes need to be made. There are budgetary concerns for some of those changes. And just quite frankly, legislators in Oregon have seen some devastating behaviors from anti-vaxxers in our state. In the past, we've had a now former legislator who had to hire personal security because of the threats made to her family by just introducing a bill with the word vaccine in it. Oregon also has a slightly different structure to our legislative session. So it's likely that no changes will be made in 2026. And if we are able to make any changes to respond to ACIP decisions, it will likely won't happen until 2027. So we are very likely going to see some confusion, access issues, and a little bit of chaos, I think, in Oregon as far as our vaccine structure. And that's it for me. I can keep it really short.
Meg, thank you very much. That was a wonderful summary, and it was very interesting to hear. Obviously, yeah, Oregon's or about the West Coast Health Alliance as states kind of try to come together to deal with this difficult time. Unfortunately, I think, we're just at the beginning to the of ACIP changes to the childhood vaccination schedule. And I do fear that there's more to come, and hopefully states like Oregon, as you pointed out, maybe down the road can come together with other states and maybe figure out what body they want to have them guide on their immunization schedules and recommendations. And obviously the American Academy of Pediatrics can play an important role there as well. So I want to thank all of our presenters and particularly our colleagues from the American Families for Vaccines in the different states and hearing about those. I know, Rose, do you want to should we have some questions or
Yeah, I have a question that I wanted to ask. And I know that many of you have been busy responding to questions in the chat box, so appreciate your time doing that. I thought those messages were just so thoughtfully written to respond to sort of the interest of the moment and sort of the messaging that's out there from perhaps those who are trying to change the existing laws in ways that might weaken access. Crystal and Carmen, I think, talked a lot more about messaging. Maybe I'm not sure if Meg talked as much about messaging. How do you guys create those kind of messaging? Do you workshop them? And then kind of related, how do you select information or communication channels that will reach your legislators that you're trying to influence and maybe the community around them as well?
Sure, I can go. Overwhelmingly, we have always wanted to try and keep our messaging pretty high level and positive. And I wanted to also say that we were not trying to platform. It's hard because you don't want to platform the disinformation, right? You don't want to unknowingly or unwittingly promote the misinformation by naming it too directly. And so by keeping it really high level and positive, like for example, we wouldn't say vaccines don't cause autism. I mean, we know that, right? Or we could say it in a nuanced way, but it's better messaging to steer away from saying vaccines don't cause autism, instead saying vaccines have a proven track record, they've been studied, and they keep people safe and healthy. Yeah. You know what I mean?
Yeah. Okay. And then just continuing on, Crystal, I know you're very strategic. How do you select those communications, whether it's a billboard or social media? Like, is there a strategy that you guys have been running with for that targeting?
We do work with media and comms people that have been doing this work for a long time. And so, doing some messaging and doing some A/B work, and actually Meg could probably speak to this better than I could. But we can kind of see which messaging lands better in some test social media campaigns and then expand it to a larger group, like doing some geo mapping. But I know Meg does a lot of great work, so I'll let her speak on that.
Yeah, so I think Crystal talked a little bit about A/B testing. I work with American Families for Vaccines to help run a lot of their digital ads, and that is really important because I think different audiences are. Can you hear me?
Yeah.
Okay, sorry, I'm nervous now. Different audiences actually respond to different messages in different geographic areas better or worse. So I think, this is a really bipartisan effort, and there are different message track that works in more rural areas. There are different message tracks that work in more populated urban areas, as well as, you have to take into account some of the culture of the state you're in. So we all share a lot of information about what's worked in our states and what hasn't. But at the end of the day, I think there's little pieces about each state that we'll bring together. And then we do heavily rely on polling and understanding, what graphic images are good to use and not. We have seen some data to suggest that things like pictures of iron lungs or pictures of severe disease are actually less effective in that kind of messaging. So we try and stay away from that. And like Crystal said, as a whole, we generally tend to err on the side of more positive messaging.
That's super
Great.
helpful. Sorry, I just want to make sure we get to the question that was not answered live, but I accidentally marked it. So I think this person was Anna was asking what resources are available to track existing state statutes and regulatory sub-regulatory guidance, as well as evolving policies. So I think that's a great one for Jack to answer with all of your experience monitoring legislation. Jack, I would also ask if you could just quickly comment on, because it's something I'm very interested in, what's behind the copycat laws? Why are we seeing so many bills pushed that look almost identical from state to state? And can you shed any light into that that trend? Thank you.
Yeah, definitely. So, in terms of existing statutes, I would point folks to immunize.org. They have a really great breakdown of requirements and what vaccines are required in each jurisdiction. NCSL, the National Council of State Legislatures, I believe, also does a really great job tracking vaccine and other health-related bills. And I would also point to ASTO, the Association of State and Territorial Health Officials. They've had some blog posts recently and general on their research and policy page all about how different states are sort of navigating these ongoing federal changes. In terms of the copycat legislation, there are several national groups similar to the groups here today with chapters in each state or with a network of parents who are on email lists and are regularly updated when bills are, introduced in their jurisdiction or are encouraging, the same bills to be introduced. So it's very much a coordinated movement. And, you can look online in some of these organizations, there's 6 to 7 sort of set bills that they sort of, coalesce around for the year. And then they'll have their advocates in each jurisdiction introduce them and then encourage sort of their membership and network of parents to be calling their legislature and encouraging, the passing or introduction of that bill.
Great. That's a great way to end, I think, Rose, right? We're right at the hour. And so I would like to, thank all of our speakers, Rose, Jack, Crystal, Carmen, and Meg, for a wonderful, informative session. It was great to hear all of the work that very important work that all of you are doing in these very challenging times. But I'll just say keep up the fight and keep up the good work. And Rose, do you want the last word?
No, thanks very much for summarizing it, Bill. And I know there's a couple questions that haven't been answered, but we'll be posting a summary of this webinar as well as the recording. And so hopefully that will be answered somewhere in the mix there. So thanks so much for all the participation on that.
Thank you, everyone.